Good evening, friends. Today we are going to discuss a very important topic in critical care because the subgroup of patients that we see in ICU, they account for about approximately 20 to 40% of all ICU admissions. These include obese, elderly, and frail patients. So why so much importance to these three categories? Because not just they are the most common patient that you see in ICU, but such patients are physiologically different. So the pathological manifestations of various disease processes is quite different. The response to treatment is different. The complications, the rate of complications are significantly higher, which ultimately lead to a worse outcome and worse prognosis. So we have with us Dr. Harsha Sinha, who will take a short class regarding these three important subgroup of patients that we see in ICU. Dr. Harsha Sinha is she has done her MD and DM in critical care from AIMS, and currently she is associate consultant and medical ICU in charge at Apollo Hospital. Welcome, Dr. Harsha.
Thank you so much. Thank you, Dr. Ruchi. Thank you so much for the introduction, ma'am. So I'll start right away. Good evening, everyone. I'm Dr. Harsha, and I'm honored to take a session on this forum. The topic for today's session is special populations in ICU, the obese, elderly, and frail. And these topics, as ma'am said, they form a very special population in an ICU. And unfortunately, we don't have too many randomized critical trials in these, but these are evolving topics of interest. We'll start with caring for the obese in ICU. We'll go through this topic. We'll start with definition, epidemiology. We'll then move to general pathophysiology. Then we'll look at the most important part, which is respiratory mechanics and ventilating an obese patient, followed by cardiovascular implications. What is the drug pharmacology in these patients? And then we'll move on finally to ICU logistics and equipment. So the WHO defines obesity as a chronic complex disease defined by excessive fat deposits that can impair health. The cutoff for obesity varies from society to society, but usually WHO says that more than 25 kg per meter square is qualifies as obesity. Obesity is a multi-systemic chronic disease, and it exerts both physical, metabolic, and molecular effects across multiple organ systems. Very often, it is associated with numerous comorbidities. They're all metabolic comorbidities like diabetes, hypertension, CKD, fatty liver, and obstructive sleep apnea. Epidemiology. The global obesity prevalence is around 13%, and it is rising with every passing decade. From adolescents to elderlies, obesity is now one of the most common comorbidities in presentation to ICU. Approximately 30 to 40% of ICU patients are obese. The numbers might be a little less currently in India, but if the trend is to be believed, very soon in the next decade, even we will have almost 30 to 40% of our ICUs who will be obese. So it is high time to understand their very peculiar pathophysiology. Obesity with BMI more than 30 is now considered a global epidemic. So what is the general pathophysiology of obesity? Coming from anesthesia background, where we used to discuss obesity very commonly, we remember that adipose tissues in these patients, they act as a separate endocrine organ. And this endocrine organ, it releases interleukins and cytokines just as transmitters, just as any other endocrine organ. These transmitting molecules are called circulating adipokines, examples like leptin, resistin, visfatin, and adenopectin. And they have multiple pleiotropic immunomodulatory effects across multiple organ systems. They are the reason that there is chronic inflammation and insulin resistance in patients of obesity. There's also impaired immunity and altered metabolism. And as we will see in the next slides, they affect almost every organ system of the body. Now, here's a picture which gives a summary of the organ system effects of obesity. Starting from pulmonary system, because it is the most important from our perspective, there is definitely decreased respiratory compliance and decreased FRC in patients of obese. Now, as we know that there is cephalad movement of the diaphragm in obese patients due to abnormal visceral fat concentration. So as the diaphragm moves upwards, the basal atelectasis of the alveoli leads to decreased FRC. Similarly, there is collapse of the smaller conducting airways, and there's collapse of the alveoli, which decreases the respiratory compliance, which means that for per unit of power, the volume that is inflated in the lungs is less. With the same reason, there is a decruitment, especially with every exhalation. Many alveoli collapse all through the lungs, and therefore recruiting them becomes more difficult. It leads to gross VQ mismatch and gas exchange problem. So there is hypoxemia and tendency to become hypercarbic in these patients. Along with that, there is increased work of breathing. Now, increased work of breathing is mostly because to inflate air into the lungs, the patient has to work against a load of chest and abdominal adiposity. To move that lung up and down takes increased additional calories. And these complications often lead to pulmonary, this pathophysiology often leads to pulmonary complications in the ICU. Coming to the next organ system is the gastrointestinal. We know fatty liver disease is very common, and this might affect the metabolism of certain drugs. Endocrine, we know there is insulin resistance, and diabetes is very common. Again, coming to musculoskeletal, these patients appear obese, but it is not uncommon to have sarcopenia underlying in obese patients. So there is difficult mobilization of these patients, frailty might coexist, and there is increased work of breathing. In pharmacology, what is most important to note is that all lipophilic drugs have an increased volume of distribution. So much of adipose tissue is there that the volume of distribution increases, and therefore the drug adjustments is maximally done for the lipophilic drugs. Hydrophilic drugs are more or less not affected. Of course, the clearance and those things we are not considering, only the volume of distribution. Then in airway management, neck and pharyngeal adiposity is common. We have difficult bag and mask ventilation, plus minus difficult intubation. It is important to note that even in anesthesia, as we used to discuss, that difficult intubation mostly correlates with the Mallampati scale. And it has been seen that although the bag and mask is difficult in these patients, intubation may or may not be difficult. It will be difficult if the Mallampati 3-4, but not as a rule. However, of course, for all intubations, we must be overtly cautious and prepare it as a difficult airway. In cardiac, there is LVH, there is diastolic and systolic dysfunction. RV mass, right ventricular mass and dysfunction is common, also because most of these patients have underlying obstructive sleep apnea, which leads to chronic hypoxemia and RV hypertrophy, right ventricular hypertrophy. Circulating blood volume is also increased, and there is increased tendency to have intra-abdominal pressure with decreased venous return. Coming to renal system, initially there is supranormal GFR because there's high blood volume and it is a high sympathetic state. So there is a supranormal GFR initially, but most of these patients are prone to CKD. One reason to be prone to CKD is inflammation. Another reason is that because of high intra-abdominal pressure, there is tendency for renal congestion. Coming to hematological system, because of this pro-inflammatory state, decreased mobilization, patients are often prone to venous thromboembolism. And the problematic part is that because the veins are not always visible, it is difficult for us to even rule out DVT at presentation to ICU. And vascular access in these patients are difficult. Even peripheral access is also difficult. And central access, even with ultrasound guidance, might be difficult because of neck fold, because of femoral fold, and there's so much of fatty tissue overlying the vessels. So overall, it is a difficult cannulation. In dermatological, again relevant from ICU perspective, is increased rate of perspiration and pressure ulcers. We know that one of the commonest reasons for having pressure ulcers in ICU is inadequate mobilization, inadequate turning, and moisture buildup in the patient's body. In obese patients, often this positioning of the patient is not done routinely by nursing staff, and this lack of logistic problems, and pressure ulcers are quite common in this cohort. This is respiratory mechanics in detail, and this is more or less what we discussed. So there is twofold insult here in obese patients. First, there is increased respiratory workload because there's high oxygen requirement. There's so much of metabolic tissue, there's so much of adipose tissue that oxygen requirement is more. type of preparation. Second, dose of the intubation drugs has to be prepared according to the weight of the patient. I'll come into drug pharmacology later. Position. So there are multiple papers in anesthesia per se who have said that these patients should be intubated in head-up position or reverse Trendelenburg position. 20 to 30-degree also helps to move the diaphragm caudally, and thus gives us more time to desaturation. So position also becomes important during intubation. Third is positive pressure pre-oxygenation. Usually the anesthesia practice also, and in ICU also for obese patients, we do not pre-oxygenate using bag and mask, but rather we ask them to breathe on their own using NIV, or we put them on control mode of NIV, and that is the pre-oxygenation before intubation. Apneic oxygenation using high flow nasal cannula is very, very helpful because again, it increases the time to desaturation and gives us more time. RSI is usually preferred rapid sequence intubation for again multiple reasons. They have delayed gastric time, and patients are considered prone to aspiration. So if no other contraindication, we can do rapid sequence intubation in these patients. Management of respiratory failure. So this is in a diagram which we have more or less covered. The first two parts is what we have just seen. The third part will come to ventilation in these patients. So when we talk about the non-invasive part, usually HFNC is recommended for all sorts of hypoxemic failure. But when it comes to obesity, because of all those problems of alveoli collapse and small airway collapsing and the diaphragm being so cephalad, NIV is recommended even before intubation as pre-oxygenation to prevent intubation, and after intubation, after we've extubated the patient. In many studies, CPAP or NIV has been shown to be a little superior than HFNC. We don't have concurrent guidelines per se, but the opinion here is more or less clear that CPAP or NIV should be used over HFNC in obese patients for acute respiratory failure. Then coming to once intubation is done, if the patient is in ARDS, we ventilate the patient as per how we ventilate other ARDS patients, but a couple of precautions have to be taken. First of all, when we calculate the tidal volume, it doesn't have to be as per total body weight. It has to be as per predicted body weight, which we know how to calculate. So this is one precaution. Secondly, monitoring of esophageal pressure becomes a little more important in this cohort when we compare it to other patients. The reason being that this esophageal pressure, which is a surrogate for pleural pressure, gives us a better idea of what the transpulmonary pressure is. So now we'll go back to the diagram that was initially put. So here, as you can see, the transpulmonary pressure is alveolar pressure minus pleural pressure. Usually in our ICUs, we are unable to measure pleural pressure because of logistics issues, and also esophageal pressure is not always easy to measure, not always validated in all sets of patients. So we skip the measurement of pleural pressure. We just measure the plateau pressure, and we assume that plateau pressure, which is the alveolar pressure, and we assume that this is the transpulmonary pressure. And we try to limit the plateau pressure up to 30. However, in obese patients, the pleural pressure becomes very important because they are elevated. The diaphragm tends to push upwards towards the apex of the lung, and the pleural pressure gradient from top to bottom is definitely elevated. So here, when we are ventilating obese patient, we see a plateau pressure of 40, we might be tempted to come down on the tidal volume, assuming that the transpulmonary pressure is very high and it will damage the lungs. But we are forgetting that this plateau pressure includes both the pressure needed to ventilate the alveoli and the pressure needed to elevate the chest wall, which in itself is heavy. So that's why it is important to measure pleural pressure in these patients so that we can get an accurate transpulmonary pressure. If this is not possible, it is okay to be a little liberal about plateau pressure and maybe accepting till 35 to even 40 plateau pressure in during ventilation of ARDS is probably acceptable. So this is one thing which is different about obesity ventilation in ARDS. Many patients need prone positioning in ARDS. Of course, it is a little risky, but it has been done. Even we do it routinely in our ICUs. It is safe, it is effective, it is feasible with help of extra healthcare workers. And we need to make sure that the abdominal position is done well, because anyway these patients have high abdominal pressure, so the abdomen should be free to breathe. And second, reverse Trendelenburg position around 20 degrees will help the patient first, also because also we are feeding the patient enterally, and it will also keep the diaphragm a little caudally, yes. ECMO and advanced support. ECMO is also very much feasible in obesity. Of course, there'll be some technical difficulty. Cannulation might be difficult. And additional drainage cannula might be needed for high BMI. Now, this is because higher BMI patients will have higher cardiac output. In VV ECMO, when we need to match the flow of the pump with the native cardiac output, or we need to cover at least 80% of the cardiac output, we need more drainage cannulas so that we can match the native cardiac output. Coming to weaning and extubation, most important part is that post-weaning, post-extubation, NIV is recommended, or CPAP is recommended. And if the patient was on home CPAP therapy, it's important to transition to home CPAP therapy in ICU itself. And prophylactic NIV after extubation reduces the risk of reintubation, reduces the risk of acute respiratory failure. And this is the norm. It's the standard of care, almost the standard of care all over the world, to have post-extubation NIV in obese patients. Now, something very interesting, obesity paradox. It used to intrigue me as well. During COVID, it became very widely spoken about, which is obesity paradox. So as we know that these patients have multiple comorbidities and are prone to ICU admissions and are prone to getting ARDS and all these infections and other problems. But it was seen in, I think, a couple of studies and one meta-analysis that their ICU outcomes are actually better than those of non-obese patients. And this came specifically in terms of ARDS. It is not a proven theory per se, it is just an observation. And even after adjusting for BMI, it appeared that this obesity paradox is true. So what are the physiological possible explanations for this obesity paradox? First, higher metabolic reserves. Now, these patients, because of adiposity, have higher metabolic reserves, and they are able to tolerate the catabolic stress of ARDS and sepsis better. This is one hypothesis. Second, selection bias for early admission to ICU, which according to me in my personal experience makes more sense, which is that an obese patient in the ward or HDU is monitored quite well, because even the nursing staff or the junior medical staff, they know quite well that even cannulation, bag and mask becomes very difficult in these patients. So there's a slightest problem, at the slightest abnormality in the vital sign, they are shifted early to ICU. So that explains the selection bias of these patients. And once they're in ICU under monitoring and in a hypervigilant atmosphere, they tend to do well because they get monitored very well. And third is misclassification of ARDS due to atelectasis. So atelectasis in a patient of ICU, if there is a lower bilateral atelectasis, it often appears similar to ARDS because of bilateral atelectasis and haziness. So this gets classified as ARDS, where usually high PEEP is used for these patients and protective lung ventilation is given, and therefore they appear that ARDS has good outcome. But originally it was not ARDS, but atelectasis. So these are possible explanations, and we'll see in future if the obesity paradox is really true. Cardiovascular implications, as we discussed, has increased blood volume, increased cardiac output, and LV hypertrophy. There is also, because there's catecholaminergic surge in these patients, baseline sympathetic drive is high. They have risk of atrial fibrillation and pulmonary hypertension. Pulmonary hypertension also because they might have underlying OSA, underlying OSA, chronic hypoxemia, RVH, and pulmonary hypertension. We have to take caution in fluid resuscitation and vasopressor dosing because of these pre-existing catecholaminergic state. In renal, obesity increases AKI risk, and mechanisms are they have underlying CKD, inflammation, and higher intra-abdominal pressure, which we discussed. So, and urine output threshold should be adjusted carefully. Now, AKI can be classified even as per urine output or creatinine clearance. Some authors say that in obese patients, we should not be looking at the urine output thresholds, but rather as at the creatinine clearance. Urine output thresholds become difficult because a person of weighing 140, 150 kg, 75 ml per hour would be the cutoff for urine, which which is often not the case. So that's why creatinine clearance is a better way to classify their AKIs. Now coming to an important part, pharmacological challenges. Now, as I had mentioned, that's usually the lipophilic drugs which bear the brunt of obesity when it comes to dose adjustment. We know that in patients, because there is so much of adiposity, it acts as a fourth compartment, and lipophilic drugs might go and settle there and tend to maintain an equilibrium with the plasma. So their dosages become difficult. But apart from the volume of distribution which increases, there are other factors also ongoing. That's why it's not an open and shut case. It's not like we can look at if a drug is hypophilic or lipophilic and then adjust the dose. There are other things happening, which is absorption, which is metabolism, which is liver metabolism, renal metabolism. Just for example, in absorption, patients of obesity often have GERD or have increased gastric emptying time. So this will affect their oral bioavailability. Second, they have increased adipose tissue and decreased lean is to fat ratio, which will affect the volume of distribution. Then there's cardiac output, liver flow, and increased high GFR in the initial phases of obesity. All these three factors, increased cardiac output, increased GFR, increased liver flow, will tend to metabolize the drug fast and eliminate the drug faster from the body. So again, as I said, that's why it's not an open and shut case. And also these patients have a poor peripheral perfusion. So the delivery of drug might not be optimal. So for example, uh, drugs like fluconazole, liposomal amphotericin B, fosfomycin, teicoplanin, these are supposed to be dosed as per the total body weight. Very recently in our ICU, for a 110 kg patient, we actually gave 1200 mg 3 doses of teicoplanin, because that is what the guidelines say, that the dosing of teicoplanin has to be by total body weight, and she recovered well and did well. Um, the adjusted body weight, which is usually midline between the ideal body weight and the total body weight, is used for dosing of acyclovir, cidofovir, and cotrimoxazole. Ideal body weight is used for the ATT drugs and colistin. ATT drugs, as you know, we usually dose by 5, 10, 20, and 25 mg per kg. There, apart from rifampicin, the other 3 ATT drugs will go by ideal body weighting, and even for colistin. Standard flat dosing is given for rifampicin and doxycycline. Rifampicin start dosing at 600 mg, or doxycycline at usually 100 mg. And TDM is also recommended in drugs like vancomycin, teicoplanin, and voriconazole, because as we know, they have a narrow therapeutic index, more so in obese. Difficult to say how much of drug toxicity can happen. So, and efficacy versus toxicity. So TDM is therapeutic drug monitoring is recommended in these. Vancomycin and teicoplanin and voriconazole. So before we prescribe any dose in ICU, it would, for obese patients, the checklist to see would be what is the renal and hepatic function. So what is the clearance of this drug? If it is a lipophilic drug, it usually gets cleared by the hepatic route. If it is a hydrophilic drug, it usually gets cleared by the renal route. Which is point number 2, medication lipophilicity. Third, what is the recommended dosing weight? And fourth, observability of medication effects. What is the effect it is causing? Unfortunately, we do not have standard guidelines putting all these together as to how we do drug dose in obese. We do have some recommendations based on pharmacokinetic studies and compartmental studies, and this is where I've picked these examples from. I have listed the reference at the end. Coming to anesthesia sedative drugs, for opioids and ketamine, we usually say that we can go by ideal or adjusted body weight and never total body weight. So although opioids are lipophilic drugs, we do not dose them as per the total body weight. We go by ideal or adjusted body weight. Same with ketamine, and observe for effect, because they're short acting. We can see the effect and then titrate. Non-opioid analgesics like NSAIDs or these we do only standard dosing, and there is no weight wise dosing, like 75 mg for diclofenac and paracetamol 1 gram, that sort of a thing. In sedatives, again, most of these general anesthesia drugs, we dose them by ideal or adjusted body weight, and etomidate is the only general anesthetic which has been dosed with actual body weight. Haloperidol and quetiapine, again, they have very narrow therapeutic index. They're known to cause QT prolongation and have other extrapyramidal side effects. So we go by standard non-weight based doses. For haloperidol, usually 2 mg, 5 mg, quetiapine also 12.5, 25. We don't have to dose them as per total body weight. Coming to another problem with obesity in ICU, there's logistics and equipment problem. And I'll just give some examples to show how a logistics problem can lead to a clinical problem. Now, pediatric hospital beds are typically 120 centimeters, have greater weight capacity, and may help with positioning and mobility. This becomes very important. So unfortunately, even in our ICU, we do not have special pediatric hospital beds, which is the case with many, many ICUs. So because they're not wide enough, if the patient wants to sit up, they will have to strain their abdominal muscles and often feel helpless. They cannot sit up on their own. So they will usually keep lying down unless somebody comes to help them. Again, mobilizing these patients become difficult because the bed is not wide enough to support. But if the bed is wide enough to support, they can turn on their own. They can be told to turn on their own. They can hold on to railings and then get up. So this one positioning problem can be solved by just providing the right size of bariatric hospital beds. So thus a logistic problem can actually lead to a clinical problem. Decreased mobilization can lead to venous thromboembolism. It can lead to pressure ulcers, poor skin health, poor integrity, and these things, and poor lack of feeling of dependence on others. So just solving one problem is going to have a multitude of benefits for the bariatric patient. Same, again, these patients have higher risk of thrombosis, higher risk of hospital-acquired infections, and higher risk of pressure ulcers. Now, these are, again, clinical problems. But if we delve a little deeper, the origins of this might be logistical problem. High risk of thrombosis might come apart from the pro-inflammatory state. It can come from not being able to mobilize, not having adequate healthcare support members to do the physiotherapy of these patients, and lack and our inability to visualize the veins and check for compression ultrasound because of so much of adiposity of the veins. So it's a logistical problem, but might lead to thrombosis. Again, hospital-acquired infection. So infection of the bloodstream, infection of the urine can happen because we don't get peripheral access. So we have a longer use of central venous access. Longer use of central venous access might lead to bloodstream infection. Also, the neck folds and the inguinal folds make the sterility of the area very questionable. Same with urine, because the patient is unable to mobilize and ask for help. We might have a tendency to keep the Foley's catheter in situ for a longer time. So again, this leads to hospital acquired infections. Risk of pressure ulcers, again, because of the same reason. Even radiology interpretation becomes difficult, as I was just mentioning that sometimes an atelectatic bilateral lung appears as ARDS. And these, even in CT scan, they say interpretation in obese patients become difficult because of scattering of the radiology wave of the CT waves because of the adipose tissue. So all in all, we can see that these obese patients have multiple problems in ICU, both clinical issues, implications, and logistical implications. I also mentioned about malnutrition and sarcopenia and difficult in repositioning and ambulation. Coming to nutrition, that is also a confusing area in obesity. The general tendency is to give them calories as per the total body weight, which is not in line with evidence. So there is no separate pointers per se in the nutrition guidelines, but at least in ESICM guideline, clearly they mention that we try to feed them with hypocalories, less calories, and extra protein. So hypocalories with somewhere like extra hypocalories in the sense like 15 to 20% per kg body weight, and proteins around 2 gram per kg of body weight is acceptable. We shouldn't try to feed them too much with extra calories because again it leads to excess metabolic rate and CO2 production and other problems of hyperglycemia because they have existing insulin resistance, etc. So that how we should feed them in ICU is hypocaloric and optimized protein. Another psychological factor is these obese patients it has been noted that they do face a lot of stigma and bias during their last interaction with healthcare. Many times their symptoms are dismissed by healthcare members. So while treating them in ICU, at least some level of compassion, it would be much appreciated. The take-home message: obesity alters pathophysiology across multiple organ systems. We have to tailor the ventilation to them, the nutrition, fluids, and pharmacology as per them. And there should be vigilance for complications, and that will improve outcomes. Now, moving on from obesity, we'll come to elderly in ICU. Again, as ma'am was saying, this is again one cohort which is increasing with every passing decade. So much so that in 2025, ESICM even came up with guidelines, consensus-based guidelines for the care of elderly in ICU. We'll go through this topic. We'll start with introduction, epidemiology, characterizations of an old person, what makes them so special, triage and admission decisions, treatment decisions, ethical considerations, ICU discharge, rehabilitation, and long-term outcome. And then at the end, we'll take a quick look at the ESICM consensus guidelines of 2025. The median ICU patient age has increased to 65 years in the last few decades. This is a problem statement everywhere, and it is predicted that in the next 50 years, almost 70% of our ICU or 80% of our ICU patients will be all elderlies. And this is a topic of great discussion now, because although ICU is a high resource, and utilization area, the outcomes for these patients in elderlies is not that satisfactory. And as many authors have said in the review articles that I was reading, they say that most elderlies, if questioned, would rather value the quality of life more than the quantity of life. And therefore, it becomes very important, complex, but important clinical ethical decision as to how much to escalate care in this cohort of patient. What are the characteristics of an old patient? Apart from the age, which is 65 plus, these patients have multiple geriatric syndromes and multi-morbidities. Multi-morbidities like diabetes, hypertension, heart failure, old stroke, CAD, these are common comorbidities. And geriatric syndromes are typical pictures of frail patients, like inability to walk fast, inability to exercise, walking slow, loss of appetite, loss of weight. These are geriatric syndromes. Polypharmacy, again, very important. Most geriatric patients who come to our ICU have at least 3 to 5 ongoing drugs, and they tend to only increase in prescription size with every passing year. Then third, there's poor reserve and increasing frailty. We'll discuss in details in frailty in a little while. This physiological changes we'll discuss in the next slide. And malnutrition. They're prone for sarcopenia, for osteoporosis, anemia, and because of poor intake. And they often have dyselectrolytemia at presentation, like hyponatremia, hypokalemia at presentation. So what are the impact of aging on the systems of the body? Starting with central nervous system, they have an increased blood-brain barrier permeability, and that is why older patients are much more liable, much more prone to getting meningitis, encephalitis, and other CNS infections. Also, side by side, very often they are high risk for delirium, and it's very common to see hypoactive delirium in these patients during ICU stay. Cardiovascular system, they have an increased resting sympathetic rate, which makes them prone to hypertension, atrial fibrillation, all sorts of arrhythmia. And it also makes them sensitive to volume changes. A little less volume and they'll be probably dehydrated and have hypotension, and higher volume, they'll probably go into fluid overload and pulmonary edema. So fluid titration becomes very important. Renal system, as expected, they have decreased functional glomeruli, and many of them have CKD. They live with CKD on dialysis. Respiratory system, these patients have poor cough and swallow reflex, even without any stroke or any motor neuron disease. In general, their ability to cough and swallow is poor, so they're present frequently with aspiration pneumonias and respiratory infections. Immune system, they have immunosense, which means that with passing age, immunity becomes dysregulated, and there is dysregulated response to systemic infection, so which lands them in sepsis, usually pneumonia, UTIs at this age. And there's, of course, musculoskeletal system is involved, which is because of malnutrition and associated sarcopenia, anemia, functional decline. Comorbidities, more than 3 are very common above 85 years of age. I would say more than 5 is becoming common, is becoming the trend now. Usual comorbidities: hypertension, diabetes, COPD, heart failure, cognitive impairment. Malnutrition, as we just discussed, sarcopenia, anemia are very common. Decreased intake, decreased appetite, poor absorption, all these are problems leading to malnutrition. Polypharmacy, also very common. What is interesting is the authors have also pointed out what we had noticed in our ICU. Many times we start drugs in the ICU to take care of the acute situation. Like sometimes we've started beta blocker or ivabradine or something from atrial fibrillation. And then it is not surprising that same drugs, cardiac medications are ongoing. Or let's say we've started diuretics in the ICU to take care of diastolic dysfunction. And the patient continues to be on those drugs even during HDU stay or at discharge because nobody has taken the effort to stop them. So this is a common problem in the Western countries also, and they have come up with some tools to encourage screening of prescriptions of these geriatric patients. Triage and admission decisions. And here, the part of ethics is where it becomes very tricky. So there is, as I said, it's a high resource setup. ICU is a high resource setup, and there's so much of economic loss for the families, and we do so many interventions, but the outcomes are never as good as what we see in the younger population. So the ethical question is, do these elderlies deserve an ICU? And the answer is that age alone cannot be a criteria. As we'll see now, that frailty has now become a universal criteria for ICU admission. But age definitely, just because a person is elderly, should not be the reason to deprive him of ICU care. Another very interesting fact I read in the review articles is that ICU also should not be the place for end of life care. Many patients who have declared to be terminally ill and are on end of life support care do not get the kind of care they need in wards and nursing homes, and they're shifted to ICU with the expectation that their analgesia and their comfort and mobilization and hydration and feeding will be better in ICUs. But this puts unnecessary burden on the ICU personnel. There is, of course, extra resource utilization, and ideally, it should not be the place where end of life comfort care takes place. We have to train our wards and HDUs better and nursing homes better so that end of life care can happen amidst family in a more comfortable area without any screens and noise and risk of delirium and risk of infection. So ICU is also not the place for end of life care. So again, coming back to triage and admission decisions, this is a simple flow chart the authors of this article have proposed of how it should go. So the first and foremost, we have to ask when a patient presents to ED is what is the patient wishes and what are the relatives' opinion on admission to ICU. Then we look at the underlying conditions, of which the most important would be frailty assessment. In triage 1, we have to ask ourselves whether the patient is too well for ICU or too sick for ICU. Both of these type of patients should not go to ICU. Too well patients, stable patients, putting them in ICU where there are no relatives, the lights are always on, there's alarms going on, screens are there, there's not a good place to be in if the patient is stable. If the patient is too sick, is terminally ill, poor sensorium, metastatic malignancy, unable to take food on his own, the ICU admission is not going to change the outcome of this patient, and therefore the patient should not be in ICU. So salvageability of the patient has to be considered before the patient is accepted in ICU. So that is triage 1, the first part. Then we come to triage 2, which is also pre-ICU, and it was more relevant during COVID pandemic. Do we have a vacant bed? Now, it is also a matter of ethics whether when there are multiple patients who deserve an ICU bed, should a geriatric patient be given an ICU bed? And of course, again, age is not the only criteria. But distributive justice, author Louis Vincent in his book says in this chapter that there's something called distributive justice. And when there's shortage of bed, probably it is more just to give the bed to the young patient, salvageable patient, rather than to an elderly. So this is triage 2. Hopefully in next few decades we will not have another pandemic, and this question will not arise whether or not we have vacant beds. Then third, once the patient comes to ICU, we do a SOFA score, we do the functional status and frailty scores, and we look at the goals of care. It is important to look at the goals of care at this end because just admission to ICU does not mean maximal support in ICU. Sometimes NIV or HFNC might be the most acceptable level of care to the family, to the physician, and to the patient. In that time, if a patient is desaturating, it's not an indication to just intubate the patient because patient is in ICU. So the goals of care must be discussed at the very onset. And then we come to day 2, day 3 reassessment. Now, day 2, day 3 reassessment, in the guidelines also they are focused on this, which is time limited trial of ICU. To reverse any acute cause, it is fair enough to give a time-limited ICU trial to these old patients, which is around 2 to 3 days. We see how much he's responding to NIV, is there reversal of AKI, is there reversal of pneumonia, and then take a call. So this reassessment, which is time-limited trial of ICU, is done within the first 2-3 days, and then a re-decision is taken whether patient should be in ICU, not be in ICU, what should be the ceiling of care. And then hopefully the patient will recover, and we discuss about ICU discharge. Post-discharge also, it is important to shift to a patient place where he'll be looked after better. So many times we shift a geriatric patient to HDU as step down, and because they cannot cough well, swallow well, we're not mobilized well, they come back to ICU after 2 days with lung collapse and inability to cough, and then the second round of ICU care starts. So it is important to shift them to a proper place, especially, and hopefully there's a special geriatric acute care unit where a patient can be shifted. So the whole focus on why these patients should or should not be admitted to ICU can be seen in this diagram. So we can see that there's a fit elderly and there's a frail elderly. And we know from experience that no two 80-year-olds are alike. They are grossly different, even if they have the same comorbidities. A person who had stroke with diabetes, with heart failure, might still be able to leave house independently, and another patient with just some diabetes or hypothyroidism might not be leaving the house independently. So frailty decides a lot of these outcome parameters. So whenever an acute stress happens, because frail patients, elderly patients have so little reserve capacities, they are hit the most, and disproportionately their reserve capacities are totally exhausted, and they never go back to their baseline functional capacity. And that is why the ICU phase becomes so important. Again, this is what I was explaining. Admission does not always mean maximal treatment. We have to balance the benefit versus burden of invasive therapies. Ethical climate influences decisions and outcomes. Here, I would just like to explain what the climate means. The authors of these review articles say that it is often decided by the societal expectations of how the elderly should be treated rather than the person, the family itself. So in religious countries and in countries where still the family culture exists, like in South Asian countries of India, China, Sri Lanka, usually the family members will not accept any ceiling of care. Usually they say that do everything. So in religious countries and in family centered cultural countries, it is difficult to put a ceiling of care no matter how much the suffering. Whereas in Western countries, they have accepted the concept of comfort care, end of life care, and it is easier to convince the family members there. In India, different things. Withholding life support is acceptable legally. Withdrawing life support is not acceptable legally in our country. However, in most Western countries, they mean the same thing, and it all basically boils down to legality, what is allowed and what is not allowed. In our country, currently at this time, we cannot withdraw any ongoing life support or dialysis, but we can withhold them with family's respect and not even initiate them. That is acceptable. Again, time-limited ICU trial approach is observed for reversible improvement. ICU discharge and rehabilitation, as I explained, there's a risk of poor transitions, and it's very important if they can go to a geriatric focused HDU or step-down unit. Long-term outcomes, even with ICU, they 50% at 12 months ICU, post ICU is their documented mortality, and more than that, almost 60% have functional decline in survivors. Quality of life may recover to age-matched cohorts for some, but not always. And just one line on caregiver burden. Often, especially in Western families where there is not much culture of joint family or sharing responsibilities amongst extended families, the burden of providing care to post-ICU patient often falls on the wife or the husband of the elderly patient who are elderly themselves. So they often suffer in silence. They don't have anybody to speak to. And as physicians, if we do come across these situations where nuclear family with just a couple, one of them is providing care to the other, getting into the hospitals and physiotherapy session, probably we should offer a support and refer them to psychologists or therapists. Quick ESICM consensus-based guidelines. There's not enough RCTs. Actually, I could not come across any randomized control trial done on elderly per se. So there's lack of good evidence. These are just consensus-based guidelines. The percentages written show how much of consensus was there within the panel. Again, families' preferences, patients' preferences are most important. Advanced directives should be sought. A time-limited trial should be most elderly should be made eligible for that. Non-invasive or HFNC might be the ceiling of care in some patients, so be careful. Offer glasses and hearing aids, early mobilization to these patients as they are very high risk for hypoactive delirium. Treatment de-escalation plans should be made as per every patient, and limit life-sustaining therapy when aggressive interventions are unlikely to achieve an acceptable quality of life as perceived by the patient. Again, a few others. Chronological age should not be used alone as a criteria for admission. Patient preferences should be documented. Decision to limit life-sustaining therapy should not be just based on chronological age. And the table here on the right side gives a checklist item. Whenever we have a geriatric patient come to the ICU, it's a good idea to go through this checklist. What is the reason for ICU admission? What is the level of acute dysfunction? How much is the functional independence? What was the pre-existing frailty, pre-existing cognitive impairments like Parkinsonism, dementia, clinical signs of malnutrition, treatment escalation plans, current residence, current support, psychosocial support system, and acute delirium screening. Acute delirium, as we know, is again very common and early. This is again a checklist for routine ICU care. We have to do the ABCDEF bundle, which is the standard of care now for delirium prevention. So mobility, early rehabilitation, nutrition, good sleep hygiene, maintaining skin integrity, minimization of polypharmacy, and early discharge planning. This is again a summary of what I have just said. Just want to add that start slow and up titrate to effect for all sedatives and antipsychotics. For all antipsychotics, they're very prone to getting sleepy or going to respiratory apnea. So for elderlies, at least, the plan, if you want to give midazolam or if you want to give fentanyl, it's a good idea to start slow and up titrate to effect. Again, key messages: triage based on frailty, not age alone. Ethical, patient-centered decision-making is vital. And time-limited ICU trial is the right of all elderlies, most elderlies. And it would be a good idea to consult a geriatrician because they know the nuances of this age group very well, much better than us. So not a bad idea to involve them in the decision-making in the ICU. Coming to the last part of today's topic is frail patients in ICU. Elderly patients and frail patients are different in many ways, and we'll just go through that. But I believe just the statement which I read, no two 80-year-olds are alike, sums it all up. Patients might have different varied comorbidities and still be different from each other, right? So we'll go through frailty, we'll look at the definitions and epidemiology, what are the biological mechanisms, and it will be good to see that all the frailty biological mechanisms are almost similar to inflammation mechanisms. Same type of cytokines and same types of inflammation, same types of pathophysiology underlying both. What are the working models of frailty? Comorbidities, functional anatomy, and frailty. Assessment of frailty in ICU, and why do we need to study frailty in ICU? Frailty is a clinical recognizable state of increased vulnerability resulting from age-associated decline in reserve and function across multiple physiological systems. A little heavy on words, it basically means that There's decline in in all physiological systems, and patients have increased vulnerability to stress, which means when it comes to everyday stressors and acute stressors like a pneumonia or UTI, they have decreased reserve to battle them. And that is why the severity of these stresses lead to a deterioration in their quality of life. It is very distinct from age and comorbidity, and we will see how. And this is a multifactorial etiology, which means that it is not that diabetes leads to frailty or stroke leads to frailty, but there are multiple issues in multiple ratios and proportions which can lead to frailty. Epidemiology of frailty, as expected, around 30 to 50% of all ICU patients are frail. Indian data of one observational study was done in the Ram Manohar Lohia Hospital in Delhi, and the frailty incidence was also similar. 38.6% patients were frail. In biological basis of frailty, again, as I said, it is mostly inflammation with cellular senescence and oxidative stress. Chronic inflammation as seen by increased cytokines and inflammatory markers. There's also the burden of chronic disease and comorbidities and phenotypic changes like sarcopenia, decreased strength, functional capacity. All of these etiological factors, they interact with each other. Something like a comorbidity, like a stroke, this leads to decreased mobility of the patient, and sarcopenia. Decreased mobility of the patient might promote venous thromboembolism, which might promote some inflammatory state, which might lead to heart failure, make the patient more frail. So this all moves in a circle to and fro. There is some amount of mitochondrial dysregulation, hormonal imbalance, hematological abnormalities, and endothelial dysfunction, also responsible for frailty. Now, what are the working models of frailty? There are three models which are now accepted. A was the physical phenotype model. It was used in the early era of frailty, when frailty concept had just started coming in 1940s, 50s, where it was a physical model. So things like weight loss, walking speed decrease in physical activity, decreased grip strength, increased exhaustion, represent the physical phenotype, which was easily recognizable. Then B came the accumulated deficits model, where apart from these physical factors, lab parameters like anemia, increased fibrinogen, decreased calcium, lab parameters or increased inflammatory markers, and comorbidities also became part of the frailty story. So accumulated deficits spoke about comorbidities, lab abnormalities, and of course the physical phenotype. And then the current model, which is most accepted, is the C part here, which is the last model at the bottom. Apart from the above two, like it includes both the physical model and accumulated deficits, it also talks about the socio-economic part, like financial limitation or limited social support. Just for an example, two 80-year-olds, both patients of stroke, one patient might be able to afford a physiotherapist or home care and have daily hospital visits, and the other might not be able to afford the same. So because of the societal and the economical factors, the frailty level in these two individuals is very likely to differ. And that is why this is a more comprehensive frailty understanding, which includes both socio-economic issues and biological abnormalities and physical impairments. Moving through the history of frailty, initial concept, it started in 1940s, where with the evolution of geriatrics as a separate topic, we started doing comprehensive geriatric assessment. In these CGAs, comprehensive geriatric assessments, the geriatrician would ask the patient to do a self-appraisal. How much can you walk? How much can you exercise? What is your grip strength? How much do you eat? What is your gain of weight? And that would give a comprehensive geriatric assessment, which turned out to be quite a helpful scale. Then a few years later, once the physicians realized that comorbidities majorly influence the healthcare outcomes, scales like Charlson Comorbidity Index or Cumulative Illness Index became popular and useful. And they are useful till date, but they're not validated for acute care settings like ours in ICUs and EDs. They're usually exhaustive, and they are useful for community settings or OPD settings, but not for EDs and ICUs. Then functional autonomy scales, using various scales, also became important. The activities of daily living like bathing, dressing, leaving the house independently, these were all functional autonomy scales, and they were also used for quite some time. After 2000s, mostly we have been using frailty and frailty scales, and one of these scales is clinical frailty scale CFS, which has been validated in multiple studies in the last 7-8 years. In fact, the literature on frailty in ICU has exploded only in the last 7-8 years, and we don't have much studies or any review articles from before that. So currently, what we are comfortable with and what is recommended is frailty score. This is what I was talking about. Comorbidities, the era of comorbidities was 1940s, 50s, 60s. Most commonly used indexes were Charlson Comorbidity Index and Cumulative Illness Rating Scale. Excellent scales, but not validated for ICU, usually for community care, OPD care. Again, functional and autonomy scales like CAD's activities of daily living ADL scale, or Lawton and Brody's IADL, instrumental activities of daily living scale, performance status. Again, they're used till date, especially in cancer patients. I've seen these scales being used, but they do not give us a comprehensive idea the way frailty scales do. So coming to frailty scales, most commonly used are frailty phenotype, 2001, mostly community based, and they restrict themselves to physical symptoms and signs like loss of weight, grip strength, appetite, etc. Second was frailty index, very extensive, includes 92 points, includes questions like, are you depressed? How do you feel your mood is on most days? How's the skin integrity, hypertension, diabetes, comorbidities? Are you able to leave the house? Do you play any sports? Multiple questions, but again, very exhaustive for ICU use. And that brings us to the clinical frailty score. It is a very compact pictographic score which can be done by the clinician within seconds bedside and has been validated in ICU and emergency use. This is what I was talking about. Frailty phenotype includes usually physical factors, and information may be hard to obtain in ED because these are physical symptoms which have to be given by the patient themselves. Frailty index, multiple health deficits, excellent scale, but not for ICU use. It gives a very good estimation of the biological age versus chronological age, because you've asked 92 questions to the patient, so it gives a very good picture of what is the biological age of the patient. Then comes clinical frailty score, which we'll see in the next picture. And it is a visual chart of 9 stages, starting from 1, very fit, to 9, which is terminally ill. And it is a strong predictor of mortality, loss of functional ability, and ability to be discharged home. There's some other administrative scales like hospital frailty risk scale, but they have not been validated for ICU, and all the more because they are done from browsing through the files of the patient. They might not paint the real picture of frailty. This is the clinical frailty score. As we can see, there are 9 stages. Initially, there were only 7 stages, but now they have been modified in the last decade to include 9 stages. First, 3 stages are called not frail. Stage 4 is called vulnerable. Stage 5 onwards includes frailty. So CFS more than 5 or equal to 5 means frail patient. Stage 8 and 9 are the worst of. They include very severely frail patients who are completely dependent, and terminally ill patients who have a life expectancy of less than 6 months. These scales have also been correlated with dementia, because patients with dementia might not be able to give us the idea of how much physical activity they can do, what is their functional autonomy. So mild dementia refers to mild frailty, moderate dementia refers to moderate frailty, and severe dementia refers to severe frailty. Frailty and ICU outcomes. I have not included the studies here because most of them are smaller studies, except the VIP study, and the results are unanimous that when compared to non-frail patients, frail patients do worse in terms of mortality, length of ICU stay, discharge to home, and functional recovery. This is a VIP2 study that I was referring to. So 2 large-scale observational studies have been done, VIP1 and VIP2. VIP1 was done in 2017 around that time, and this is VIP2 done around 2020. They were both published in Intensive Care Medicine. VIP1 observed the incidence of frailty and elderly age group. VIP expands to very elderly patients in ICU. This is the expansion. And in VIP2 study, which was done on almost 3,920 patients with a median age of 84 years, they found that clinical frailty score remains an independent factor after inclusion of life-sustaining treatment limitation in the models, and it is able to predict short-term mortality and should be routinely collected for all elderly ICU patients. This is again a chart which very nicely depicts that when a frail patient is admitted to ICU with some diagnosis, the loss of function after discharge from ICU is disproportionately much higher than the loss of function of a non-frail patient. So if a frailty score patient with a frailty of 7 is admitted with pneumonia and patient with frailty of 5 is admitted with pneumonia, patient with frailty of 8 might never go back to the frailty of 8, might have a frailty of 9 during discharge from ICU. So this is again another reason why admission to ICU with higher frailty scores must be taken with a lot of caution after discussion with family and multimodal discussion. Organ supports, as expected, they need more organ support. The outcomes are also not as good as for younger patients, and they're likely to receive less aggressive support because the patients might have some limitation of upper limitation of care. Predictive models, just a quick line. Apache and SOFA is what we calculate routinely in ICUs for severity of disease, and they have correlated very well with outcomes of patients in ICU. So now these models are saying that also incorporate frailty calculation, CFS score, when we calculate SOFA score, and that gives us a much better idea of the outcome of the patient. Like this study, again published in Intensive Care Medicine, just 2024. One of the authors is Rinaldo Bellomo, who is a very prominent nephrocritical care enthusiast, and he has written a book on nephrocritical care. So they studied that if persistent critical care illness, which is a critical care illness beyond 10 days, which is called PERCI, so they said that when compared with the admission diagnosis, actually the frailty score gave a better idea of the outcome of the patient. So if a patient came with pneumonia, beyond 10 days, whether or not patient will still be in ICU is reflected more in frailty scores rather than the severity of pneumonia. So this is a very relevant understanding, throws light on the importance of frailty. And maybe that's why we should start doing frailty scores routinely in our ICU. Just an editorial from Intensive Care Medicine, published 2023. They say every elderly patient, there should be assessment of frailty, there has to be measurement, there has to be interpretation and taken into account before we do the decision making of treatment, of end-of-life care, time-limited ICU trial, advanced care planning, and discharge planning. So frailty score measurement is probably going to be the change that I would like to bring in my ICU. Limitations and research gaps. Of course, there's lack of randomized trials in this field and a lot of research gap. And there's one risk of using CFS. It reduces a patient to scale or number. Just looking at a patient of a frail patient of 7 and refusing admission to them, like looking at a 90-year-old and refusing ICU admission to them, is probably some amount of discrimination. And when we don't give them ICU care or deprive them of all aggressive therapies, we are actually doing a self-fulfilling prophecy because they're bound to have poor outcome. So that is why these are clinically complex and ethical decisions, but just based on CFS or based on age of the patient, we should not do the triaging or the treatment decisions of the patient. Everything has to be looked at comprehensively. Key messages: that frailty is an independent modifiable risk factor. Integrate frailty into triage decisions, management decisions, and follow-up of ICU patients. And the future is that personalized ICU pathways integrating the frailty metrics. These are my references. Thank you so much. Thank you to Ruchi ma'am and Dipesh sir. I really had a very nice time studying these topics because I would have otherwise not delved so deep into these topics. And yeah, thank you so much. I'm open to questions.
Thank you, Dr. Harsha. It was very complete, very comprehensive, and a very practical lecture in which you covered all the 3 subgroups in a detailed fashion. So thank you. As you rightly said, these three subgroups, obesity, frail patients, elderly, they have significant physiological changes which affect our management plan, give us unique challenges when we manage such patient, and definitely our prognosis is affected by how we manage these patients and per se because of the changed physiology of these patients. Obesity, you have summarized all three subgroups very concisely in your lecture itself. Obesity definitely is a special challenge that we commonly face in our ICU. We need to be very much aware about the changed pharmacokinetics of the drugs that we give an obese patient. Underdosing of antibiotics is very common. We need
Yes.
to understand the lipophilicity and the hydrophilicity of the drug and modify the doses accordingly. We have become more aware. We are doing weight. We are in our own ICU itself. We are practically we have the weight measurements in the bed itself. So we are doing weight measurements, calculating the adjusted body weight for all the obese patients and even severely malnourished patients to give the drug dosing accordingly. Obese patients, especially, they give us, as you said, they paradoxically, they have good prognosis, which we have observed in most of the ICUs, even in India, despite the Western data, even our data is the same. So these patients definitely are challenging to manage, but very satisfying when you get these patients out. Same thing goes with elderly. In elderly, you have to see humans beyond machine. This is what you learn when you look at elderly patient.
True, true.
It is not just the diagnostic and the therapeutic challenge. It is also the socio-economic aspect, the family wishes, the patient himself, their wishes themselves about the kind of care plan that they have in mind before getting admitted in the ICU. So these are a special population, needs special care. We need to have a logical approach to this such patient, taking into account the special needs of the subgroup. The most importantly, the physiological, pathological, psychological, and the socio-economic aspect. Same thing goes with the frail patient. Thank you, Dr. Harsha. I do have a question. In obese patient, how do you titrate PEEP
Yes.
in your
So,
ICU?
yes, ma'am. So, there are, the obvious understanding is that these patients will require higher PEEP because they need every end expiratory alveolar collapse is very common in these patients. So, they need a higher PEEP. But there have been studies comparing higher PEEP up till 2022 and moderate PEEP around 12 to 14 in these patients, and they have not showed any gross different in outcome. So, if the hemodynamic parameters are acceptable, we can go on higher PEEP and then monitor as per response. So, yeah.
So are you using ultrasound in your obese patient to look for atelectasis in patient who are mechanically ventilated or a patient who is having hypoxia? Even to
Uh,
titrate PEEP? Because we do not have transpulmonary pressure in our ICU, but we
no.
sometimes use ultrasound to look at basal atelectasis. But it
Yes,
hasn't helped us
that's
in
a very good.
titrating PEEP.
We can use that. No, I'll be honest, we don't use it in our ICU. But again, as I remember, ultrasound cannot tell us about overdistension. It can
Yes.
tell us if atelectasis is there, but it cannot tell us overdistension. So if the hemodynamic parameters are permissible, I usually give around 14, 16. I'm comfortable with that, but I have not gone to 20, 22, ma'am.
Even we haven't. And another thing, in DVT prophylaxis, are you using enoxaparin or low molecular weight heparin at the initiation when the patient comes to the ICU itself, or you wait for a while in obese patients specifically?
No, ma'am, we start right away. We don't
Okay, right
make
away.
any delay, and as per creatinine clearance, we'll either choose UFH or low molecular weight heparin.
Okay, so same practice we are also following because we recognize them as the high-risk group. And
Exactly.
as per the hospital protocol itself, we also start pharmacological DVT prophylaxis immediately after the patient gets admitted to the ICU. Thank you, Dr. Harsha.
Thanks.
So, thanks, Dr. Harsha. I was able to join, thankfully, and I was lucky to listen to this. Very nice, very detailed, very elaborate. A lot of work has gone into that. Wonderful. And thank
Thanks.
you, Dr. Ruchi.
Thanks.
Nice for you to moderate this. So, if there are any questions from the audience, we take the questions. I'll just add a few things. So, first of all, Dr. Ruchi, you were asking about the PEEP in this. Obviously, if you have a esophageal catheter, which most of the ICUs don't have, it would be the best thing. But the way to go about it is the practical way is you keep increasing the PEEP slowly. So when you keep increasing the PEEP, the bladder pressure goes up, and the pulmonary pressure will go up. The pleural pressure goes up, and it affects the right ventricular output. So slowly go up, and once the right ventricular output starts decreasing, your cardiac output starts decreasing, then your blood pressure will start decreasing. So that is the cutoff. So you keep it a little below that. That is the most practical way without the esophageal catheter in patients of ARDS. And other than that, we normally keep a PEEP of 5, right? If the lungs are kind of okay to counter the atelectasis on the ventilator. So you can go up to 8 because there is more atelectasis in these patients. So that is about PEEP in obese patients. And moving on, so we have these groups, right? The frail, the elderly, and the obesity. That is what we are seeing in the ICU now. We hardly see young patients, who are non-obese or fit, or it's mostly elderly or frail or obese. So this is a very important lecture, and I'll just give a couple of case vignettes. So we had this elderly patient who came in with the urinary incontinence and obtundation of a very short duration, 2 days, and it was not clear. A lot of tests were done, and then we just kind of looked at it more carefully because nothing was coming out, and it was just fever. He had developed a viral fever. So in the elderly, he was 85 years old, and there was some background slowing of the brain, some kind of a neurological illness. So these patients they get obtunded very easily. The elderly, just a fever of 100 degrees, they go into obtundation, urinary incontinence, and unnecessary testing is done. So that is very, very important because the brain slows down. And then again, we have to look at the quality of life. Like Dr. Ruchi was saying, the quality of life is very important. A 90-year-old guy who's reading the newspaper, who's going for a small walk, who can feed himself, definitely he should be given a chance. We have sent 90-year-old people home. There was a septic shock patient. There was 85-year-old lady who had VT, MI, VT, cardiac arrest, angiography, and she went home and she lived on for 5-6 years. So the quality of life is very important. On the other hand, a 65-year-old guy who's got Alzheimer's dementia and he cannot look after himself and is dependent on others, and he comes with ARDS or some multi-organ failure, you have to discuss with the family and you have to address the issues and not escalate treatment. So that is very important. Is the biological age rather than the chronological age which matters here. Mm-hmm. And the other thing is about just a few things about the obese. I think you have said a lot of things about fluids. So fluids, you have to adjust the body weight. I think you mentioned that. So you take the difference between the actual and the actual and the
ideal body weight.
Yeah, predicted body weight, and you take half to 1/3 of that difference and you add it to the predicted body weight. That is how you use fluids. And same thing for drugs. You've given a lot of details for drugs, but as a rule of thumb, that is how you just go about drugs and fluids. And then adding about intra-abdominal pressure, we have to be very careful with the fluids here because they already have a high baseline intra-abdominal pressure, which can affect the renal system. And the other thing is about this thing. What was it? Obesity paradox. So the obesity paradox is a very controversial thing. Initially, it was said that the ARDS patients who are obese have a much better outcome, but this has come into some kind of a controversy, and you showed some reasons. But the other factors such as increased cardiovascular complications, they get MIs, they get strokes, and these things increase the mortality also. So this has also been looked into now. So it's not very clear. It is said that ARDS obese has a better prognosis, but then the other complications like myocardial infarction and strokes and all come into the picture. And apart from that, just coming to urine output, again, there's no clear urine output definition. So if you're trying to use urine output definition for oliguria and all, that actually becomes haywire. That's also not clear again. Then the other thing is for obesity, sleep apnea. These patients are very prone to obesity, obese sleep apnea. So that is again a very important thing where P2 goes up and all those things happen. And when you have this obesity, sleep apnea, or obesity hyperventilation syndrome, they're very much predisposed to a depressed respiration with the narcotic drugs and such drugs. You give them a very small dose, the respiration will just dip. So that is another component which is not really looked into because sometimes they don't report that. They may be just having a baseline and you give them a little bit of fentanyl and all, suddenly they'll stop breathing and CO2 will start rising. So this also happens where we have to be very cautious about this. And apart from that, pulse contour analysis. So you see, the basis for pulse contour analysis is a normal population. They have not looked at the parameters of a obese subset. So the pulse contour analysis is not always accurate in these patients. So the parameters that you get are a little off the mark in these patients. And just that was a few things I wanted to say about obese patients. I'm just coming on to the elderly. So elderly, I've given you examples. We have sent I've sent many 90-year-old, 85, 90-year-old people home, and they have lived on, and the family has really been grateful. And there have been others like 65, 70-year-old where we discuss with the family because there is no quality of life. At the end of the day, it matters how these people are doing at home, whether they are able to read the newspaper, watch some TV, interact with the grandchildren, and so on and so forth. Then about the physiological changes in the elderly, one, the heart rate goes down. They often have 6 sinus syndrome, right? And second, they will not mount high temperatures. Third thing is the PO2. The PO2 can dip down to 70. As you start aging, the PO2 starts dipping. Why? Because the lungs become emphysematous. Lungs become emphysematous. So as you age, the lungs become emphysematous, the lung compliance increases. The chest wall compliance decreases because the rib cage starts kind of becoming rigid. So these changes start occurring with your aging, and also the GFR goes down. So GFR is around 110, 120 when you are young, 18-year-old. But at 70, it's supposed to be 70. If you are good, if you had some insult which was not recognized, it will probably be even lower. So just a few things I wanted to add from my side. And I think with that, we shall kind of come to a conclusion to the comprehensive lecture from your side, and very nice additions from Dr. Ruchi. And we shall meet again after some time. And with that, we shall come to an end. So, Dr. Ruchi, should we close it?
Yes, sir, definitely. Thank you, Dr. Harsha. Thank you, sir, for inviting us to this lecture. And it was very comprehensive, as I said, but very, very complete. Thank you, Dr. Harsha, for the effort that you have put in the lecture. It was great.
Okay. Bye-bye, everybody. And namaskar, dear viewers. See you again. Thank you, everybody. Good night.
Thank you. Thank you, sir. Thank you, ma'am.
Sir, thank you.